Hey, Dr. Gullberg, continuing our infectious disease series today. We're talking about HIV infection. This is the second in a series of 3. Today we're going to talk about confirmatory tests, resistance mutations, when to initiate therapy, and a little about chemotherapy. So in terms of confirmatory tests, obviously the HIV ELISA test is the screening test. There's very few false negatives with this test, but we do see more false positives. So then we have to confirm with a Western blot test. If that's indeterminate, then of course you can do just HIV quantitative viral load testing. As we treat patients, obviously we're monitoring the viral load, we're monitoring the CD4 count, and sometimes we do genotyping to check sensitivities of the agents that are effective for HIV, especially when resistance can start occurring. So speaking of resistance, there's a couple of different resistance patterns that we see. There's a major NRTI resistance mutation at M184 and the case 65, as well as the 215 TAM, or the thymidine analog mutation. The major NNRTI resistance mutation is at K103. And the major protease inhibitor resistance mutations at 154 and V82. We watch for mutations regularly. When do we initiate HART therapy? Well, if the CD4 count is less than 200, no matter what the viral load is, we start HART therapy. If the CD4 count is between 200 and 350, then HIV viral load must be greater than 20,000 in order for us to start therapy. If the CD4 count is greater than 350, then we'll initiate treatment only if the viral load is greater than 60,000. HART therapy was developed in 1995, also standing for highly active antiretroviral therapy. Triple therapy with meds from at least 2 classes is really how we usually go about treating. Usually we have 2 nukes and an NNRTI, or 2 nukes with a PI, or a protease inhibitor such as Kaletra. Chemoprophylaxis is also very important with low CD4 counts. We're trying to guard against infections such as cryptococcosis. We'll use fluconazole for prophylaxis for that, and bad candida infections such as esophagitis. We'll use azithromycin for prophylaxis against MAI or dissemination. We'll use ganciclovir for CMV prophylaxis, and we'll use, of course, trimethoprim sulfa or Mepron commonly for pneumocystis prophylaxis as well. So definitely need to know about chemoprophylaxis, but more importantly, the HART therapy that we use. Next lecture, we'll talk a little more about specifically about the agents. Thanks, Dr. Gullberg signing off.